Welcome, everyone. Thank you so much for joining this month's Fireside Chat in honor of Breast Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. So the Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. Our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Engagement Coordinator on our team, and on behalf of our team, thank you all so much for joining us today in observance of National Breast Cancer Awareness Month. Breast cancer is the most common cancer diagnosed worldwide. In the United States, it is the second most common cancer diagnosed in women, and it is the second leading cause of death from cancer among women. Breast cancer can be easily treated when detected early. So today we are joined by breast radiologist Dr. Noelle Hoven and breast cancer survivor Lei Simmons for an important discussion on breast cancer screenings, understanding the risk factors, and what to expect at a breast imaging center. First, we will be hearing from Dr. Noelle Hoven. Dr. Noelle Hoven is an assistant professor in the Department of Diagnostic Radiology at the University of Minnesota, and she is the associate program director for the Diagnostic Radiology Residency Program. She graduated from the College of St. Scholastica in 2003 with a major in biochemistry. She is a Minnesota lifer who attended the University of Minnesota campus for medical school, diagnostic radiology residency, and a breast imaging fellowship. In 2019, the Minneapolis St. Paul magazine designated Dr. Hoven as a top doctor rising star. She is incredible, and we are so honored to have her join us today. I will introduce our second speaker, Lei Simmons, later on in our program. We will be recording today's session, so you can refer back to the recording on our YouTube page. Before we begin, I would like our audience to get familiar with using the Q&A feature that's going to be located on the bottom right of your screen. During today's presentations, please use the Q&A feature to submit your questions. All right, now without further ado, I will pass it on over to Dr. Noelle Hoven.
Okay, thank you so much for that kind introduction. And I'm watching as the attendees join, and I'm blown away by the attendance. Thank you so much for asking me to come and for taking time out of your day to come and listen and learn. My name is Noelle. I am a radiologist at the University of Minnesota, and I was asked to kind of go over breast imaging. And I like the idea of chat, because that is what this is meant to be, just a chat, a very informal overview of breast health and imaging. And so thank you again for tuning in.
Dr. Hoven, you are muted.
Yes, today I'll be discussing how we evaluate for breast cancer, what to expect. We'll review a handful of cases, and I'll go over some imaging features. We'll talk about some risk factors, and I'll try to incorporate some of the questions that were already submitted in my review. And then we'll also go over some common benign or non-cancerous, not bad breast findings that we commonly see in clinic that patients can present with. Now, I am a teacher for the residents in our program, and I understand listening to a lecture can be pretty overwhelming and it can be a lot to absorb. And so I try to give some highlights of what I would like for you to take away. And so for today, for those of you in the audience, I'm hoping that after hearing me, you remember these three things, please. Number one, annual screening mammography begins at age 40 for the average risk patient. So for most people out there, I'm going to encourage you to begin screening for mammography at age 40 annually. Number two, persistent symptoms, specifically in one part of one breast, deserves evaluation. We'll get into that here in a little bit. And then number three, a common misconception, but I want to get the record straight, is that most women with breast cancer do not actually have a family history of breast cancer. So we'll touch base on these three things, but these are the three main takeaways from my talk today that I hope you can remember, please. So breast cancer detection, why is this so important? You know, Amna mentioned at the beginning how common breast cancer is for women. And what's very, very important is that we have appropriate access for patients. We have identified, you know, the stage of presentation as early as possible, an early diagnosis, and then we effectively manage breast cancer so we can improve a patient's ability to stay alive and decrease any chances of complications from breast cancer treatment. So for that to happen, a lot of patients will ask me, what is the biggest thing I can do to reduce my risk of breast cancer? And this is sort of the takeaway. For an average risk patient, please start screening mammography every year at age 40. Unfortunately, there's a lot of confusion. Different societies are saying different recommendations. And so when you come to the breast center and you get a letter, the recommendation from radiologists, and I say the breast imaging experts, will include this statement: annual screening beginning at age 40, or continue annual screening if you are over the age of 40. This has been shown to have the biggest reduction in cancer risk if you continue to screen every year starting age 40. So what is a screening mammogram? It can be confusing because you may have heard of some of your friends, or maybe you yourself have been asked to come back for a mammogram or to have a diagnostic mammogram. And so I'm going to start in this box here. A screening mammogram is for patients that come into the breast center and they have no symptoms. So typically this is performed on an annual basis, once a year. They have no symptoms. I'm going to stress that because that's a common thing that patients get confused about. This is for an asymptomatic patient. She comes in, she gets 4 images taken of her breast, she goes home, and then typically the exam is read the following day. That's just sort of standard for most breast centers to read the exams that are performed. Like, for example, today on Wednesday, all of these screening mammograms that are performed today are actually read tomorrow. And then eventually you receive a letter in the mail, or more likely today, if you're part of an electronic health record, MyChart, for example, you'll receive those results in almost instantaneous once the report is finalized. We as radiologists are legally obligated to get you a report, though, a written report to you in a way that you can understand the results within 30 days of your mammogram. So that is something that we are legally obliged to do. On the other hand, in this box here, a diagnostic mammogram tends to be associated with some sort of consultation with a radiologist. So you still will come to a breast center, but this might be in the context of a particular symptom that you're having. Maybe you're having breast pain. Maybe you feel a breast lump. This is a different assessment than a screening mammogram, which is why I stress the fact that you don't have symptoms in the context of a screening mammography exam. If you have symptoms, it may require additional imaging and a review by the radiologist while you are in clinic. So that's the important distinction. Diagnostic mammography is also for patients if you've had a mammogram and we ask you to come back for additional views. Maybe we want to take a closer look at something that we saw in your breast at the time of your screening mammogram. And so we may ask you to come back for additional pictures. And then sometimes patients who have had a previous history of breast cancer or who are undergoing breast cancer get a diagnostic evaluation as follow-up thereafter. And so I try to say that this diagnostic mammography assessment typically comes with a consultation with a radiologist. It's sort of like a clinic appointment, as opposed to a screening mammogram where you come in, you get your images, you go home, and then you eventually get the result in the mail or through MyChart. Next, what I'd like you to take away is, a lot of patients will ask me, well, how do I know if I have something that's suspicious in my breast? What are the symptoms of breast cancer? And it can be really difficult to describe all the different possibilities of how cancer can present. And so I had a mentor who explained this to me, and this is how I explain it to patients now. pay attention to changes that develop in your breast and stay there, especially if they are in one part of one breast. So breast pain is very common. When it's bilateral and it's all over, or it's bilateral, both breasts and in the outer parts of the breast, for example, and it comes and goes. It may be worse around the time of your menstrual cycle, or it might be worse in the beginning of the day, but by the end of the day, it gets better. That tends to be a reassuring symptom. It's bilateral. It's occurring in multiple parts of the breast. That's oftentimes what we classify as physiological pain, and we could discuss that in clinic. On the other hand, if you're taking a shower one day and you notice there's a lump and it's only in your left breast, and you've never noticed that before, that is something that should get your attention. Pay attention to that. If it's something that's new, or if you've never noticed that before, or you give it a week and you're like, it's still there, that is a persistent symptom that we would want to encourage evaluation either by your physician, or maybe your primary care physician, or seeking a consultation directly to us in the breast center. So persistent symptoms in one part of one breast. So how do we look for breast cancer as breast radiologists? So there are two components to my job. One is the clinical evaluation, and that's getting back to sometimes patients will come to us with a concern, and again, that one part, one breast. And then we also have our imaging tools. In breast, we have mammography using x-rays, ultrasound using sound waves, MRI, contrast enhanced mammography is offered at our breast center here in Minneapolis and at Maple Grove. Getting back to symptoms to pay attention to, this is from a website, Know Your Lemons, and I really like this visual. It is a bit curious that they found lemons to explain breast cancer symptoms, but I think it does a really nice job of covering a lot of the things that we want patients to pay attention to. Again, baseline, something new that's happening in one part of one breast in particular, but that could mean feeling a thicker area of the skin. You have some dimpling that's developing. You have changes around your nipple or new skin sores that are developing. Leaking from the nipple itself, we call that nipple discharge. Maybe there's skin discoloration. It could be red, or it could be developing kind of a thickened orange peel, like an orange surface texture to it. Maybe you feel a hard lump. Maybe your nipple is starting to pull in and in and in and in, and that's new. So these are some things that are something to keep in mind, but again, not to be so literal, because if something new is developing in your breast that you've never noticed before, it's better to err on the side of caution and have it evaluated. So we got into this a little bit, but we have mammography. And so this is showing a patient who's gowned. The technologists are, I'm really proud of the team I get to work with. They really do their best at making patients feel as comfortable as possible given this type of exam. They really want to work with patients to make this as comforting as possible. And so they do a really wonderful job. These are the standard views when you come in for mammography. So there are two views here. We call those the craniocaudal views, where the breast is compressed from top to bottom like this. And then this view where they're compressed sort of side to side. So those are the four standard views that you could expect to obtain, typically with you standing, although they can perform mammography with patients seated or in wheelchairs. Each mammogram will have a density classification to it. And so you can see on this far end, patients that have mostly fat in their breasts, all the way to what we call extremely dense, where there's more of the white or fibroglandular breast tissue. And if I show this kind of an example of what a cancer could look like as a mass, you can see how it becomes progressively more difficult to see in someone with a very dense breast. In Minnesota, we are one of the states that has to notify a patient if she has dense breast tissue to know that she is at increased risk. One, it's harder to detect breast cancer. It's harder to see on mammograms. There's more breast tissue. It's more dense, I should say. And so there may be a point at which she could have a discussion with her primary care provider, physician, I should say, about additional screening options for her, such as MRI, for example. This is not an abnormality. This is a grade that every patient gets on every mammogram. So this is just some examples. I want to share some cases of what breast cancer can look like on a mammogram. So here you can see a mass where the arrow is pointing. This is an example of contrast enhanced mammography at our breast center, where a patient presented for a known mass on the right and inadvertently during the contrast exam, or I should say incidentally noted, was found to have a cancer in the other breast that was detected at the time of contrast mammography. So we've really enjoyed using this technology in our breast center, and we've found it's been really helpful for detecting additional cancers and for staging. This is an example of an ultrasound machine. So typically it's live, it's used by a technologist, and in our breast center, we also scan ourselves, each patient that comes through for an ultrasound evaluation. Typically you're lying on a bed and there's gel. And then this would be an example of a suspicious breast mass on an ultrasound. And so a lot of times patients want to know, why do I need a mammogram and an ultrasound? And I like to say that they tell different stories. They're different technologies. They are often used together to understand what's going on in the breast tissue. And so for patients who are over the age of 30, if they're coming in with a symptom, we are going to start with mammography. If they're under the age of 30, we will start with ultrasound because the risk of breast cancer is much lower. And so if the ultrasound is negative, we may at that point discuss with the patient stopping at that instant in time and discuss about clinical follow-up if her exam is negative, for example. So again, we are comparing with ultrasound, we're doing live scanning, we're comparing, we're looking for differences. A lot of times patients ask, how do you know what cancer looks like? And it's also similar, it's sometimes, a lot of times it's not this easy, but we're looking for changes in the breast. And so, you know, this breast, you can see nice uniform gray throughout. And in the area of where a patient has a palpable concern, you can see this very heterogeneous or dark colored mass here. And this looks different from this side. And so this becomes suspicious. It's an area that the patient is feeling. And so this is something that would warrant additional evaluation. And in this situation specifically with a core needle biopsy. And so ultrasound, mammography, we'll get to MRI in a minute, all have the ability to allow us to use those modalities to guide our ability to biopsy suspicious findings in the breast. I'd say biopsies and procedures in the breast center are overwhelmingly tolerated by patients. We do our best to make them as comfortable as possible. It always breaks my heart when I hear stories of patients having a terrible experience because we really do try our best to give them enough local medicine to help minimize pain and discomfort and keep them distracted throughout the procedure to make it as comfortable as possible that we can. Results at our breast center from a biopsy typically come within 2 to 3 business days. This is an example of a breast MRI. A lot of people, even in the health field, don't know how breast MRIs are obtained. So this is just 2 examples of how breast MRIs are obtained. So the patient is lying on their stomach and the breasts are somewhat suspended here, and they enter in the MRI scanning machine. Typically, MRIs are performed if they're screening for breast cancer with the use of a contrast-based exam with a peripheral IV. So I'm kind of going fast here in the interest of time, but again, annual breast cancer, age 40, why does all of this count? Why does all of this matter? Timing of diagnosis is so crucial when it comes to breast cancer. If we can diagnose, if we can catch breast cancer earlier, the likelihood of appropriate treatment goes up. We want to catch cancers when it's smaller in size, so the stage is better. It decreases, or the smaller the cancer, it minimizes the risk for distant disease. So timing of diagnosis is so important. And that's why it's important to come in if you have a symptom or if you are of age to have annual screening mammography. A couple of cases too, just to illustrate, a lot of patients think the minute I have breast cancer as a diagnosis, it's a death sentence. And I just wanted to shed some light on some real cases that we've had showing the power of the treatment that exists. And so this is an example of an MRI scan, and this is showing month 1. and a pretty sizable tumor, several, 5, 6+ centimeters in size. After 2 months, this starts to definitely decrease in size. And at the 6-month mark, much, much smaller. This is the residual cancer that's left with treatment. So treatment, collaboration, multidisciplinary involvement with our oncologists, our surgeons, has done wonders for breast cancer treatment. This is another example of tumor response. So this is the first month. You can see this mass here in the left breast. And at the 3rd month of treatment, you can essentially see resolution of that enhancement, almost a complete response based on imaging alone. So very, very excellent response to chemotherapy or neoadjuvant therapy. Sometimes patients think if I have a symptom, it's breast cancer, I'm not going in, but I want to share that we see a lot of other things on our breast imaging that is not bad. It's what we call benign. Calcifications are very common. Calcifications can come in the form of arterial calcifications. We call these secretory calcifications. They're another type of benign calcification. And then we call these popcorn calcifications. Essentially, calcifications are the same as, calcium deposition that you have in the bone. I call them little white dots on the mammogram. And sometimes they require biopsy if they're not fitting into this bucket here of benign calcifications I'm showing you. So calcifications are something that we commonly see on our breast imaging. Here's another pictorial image here from the radiology assistant that talks about these are more suspicious calcifications that might be developing in the ducts. But that's something that you wouldn't necessarily and most likely not be able to feel, but we could detect on mammography, which is why screening is so important. Here's another example of vascular calcifications. So these are calcifications that are developing or forming in arteries. And then there were some questions about male breast disease. And so I just wanted to show an example and to describe the fact that men can get mammography, and we do see men in our clinic with symptoms. And so sometimes it's surprising for people to know that men can have mammograms. And so I'm here to say, yes, men can have mammograms. Gynecomastia is a benign breast tissue development that can occur in men. It's quite common. It can be on one side or both. And we can see that easily on mammography. If that's seen, occasionally we'll do ultrasound, but we may be able to stop if the mammogram is pretty classic. Men can also get breast cancer, although the incidence is much, much lower than women in breast cancer. And so there is no formalized widespread mammogram screening program for male patients. I have some stats here. About 1% of all breast cancers are diagnosed in men. And so for comparison, on average, the lifetime risk for a woman is about 1 in 8 women for lifetime risk of breast cancer versus men, it's about 1 in 1,000. And so when I'm counseling male patients or family members who ask about male patients, I'm giving the same type of advice, but in the form of clinical findings. So if a male develops symptoms in his breast and they persist and they're especially in one part of one breast, he should absolutely come in and not delay. Male breast cancer looks a lot like female breast cancer. And so it's important that if a man has a symptom, to not ignore it. And to remind your male friends or family members that, mammography is a possibility for them too, and that they should absolutely seek medical attention if they are noticing new changes in their breast tissue. Just an example of lactating breast. And so sometimes patients want to know, I'm breastfeeding, I was told I shouldn't get a mammogram because you can't see anything. Well, you can see before a patient is lactating and during lactation, the breasts are much larger. There's a lot more fibroglandular, proliferation tissue, so it looks much dense. However, if the patient has a symptom, particularly a lump, we still recommend that they come in and get evaluated. Breast cancer, pregnancy-associated breast cancer is a very scary situation. Those cancers can be aggressive, and we don't want to miss them. And so even if a patient is lactating, I think it's still important to not delay evaluation. If a patient declines mammography, we can certainly continue with ultrasound, but I would probably have that discussion with her about the importance of mammography, even in the context of a lactating breast. It's possible to still see suspicious calcifications, those little white dots on the mammogram. Occasionally, depending on where if there's a mass, we could still potentially see that. So there is additional information that can be gathered on a mammogram for a patient who is breastfeeding. And then lastly, a couple of things here, some risk factors for breast cancer. Age is one. As we get older, our risk of breast cancer increases. If you have a genetic mutation, there are now genetic testing has become much more expansive in terms of the panel that they're running to look for genes. Common genes people have heard of, maybe the BRCA or the BRCA gene, but there are a lot of different genes that have been associated with breast cancer. So if you have one of those, that may put you at an increased risk for developing breast cancer. Reproductive history, so not having children or later longer exposure to hormones, you're menstruating longer, that sort of thing without interruption can increase your risk. Dense breast tissue we talked about, a personal history of breast cancer, you may be followed more closely as a result. If you have a family history of breast cancer, that's something to pay attention to. Know what's going on in your family. And then prior radiation therapy, we call that mantle radiation. If a patient's had lymphoma at the age between 10 and 30, they may be at increased risk for developing breast cancer later in life. And as a result, we may begin screening them earlier than age 40 with other, mammography or MRI, for example. Actionable risk factors, these are the things that we may not have the ability to change, but we can make sure we're getting plenty of physical activity regularly. We can do our best to maintain a healthy weight. We can do our best to limit alcohol use and try to avoid smoking. So these are some things that you can work to minimize your own risk, work on. So this is an example from Mammography Saves Lives, and it's a nice way of going over a patient if she's called back. For every 1,000 screening mammograms that we read, on average, we may ask 100 of those patients to come back for additional pictures. Most of those will be normal, and they can continue on to their screening every year. Maybe 20 of those, we may say, 20 of the 1,000 patients, we might say, hey, instead of seeing you back in a year, let's see you back in 6 months. And only 5 of those patients out of the 1,000 may be ultimately diagnosed with breast cancer. And so I think it can be scary to have a screening mammogram and be called back, but it's still more likely that things will be okay and normal. If anything, it's a short-term follow-up. And if it's a biopsy, hopefully we're able to give you counsel on whether we think this is suspicious or we're just trying to prove that something is benign, nothing to worry about. And then lastly, I'm almost done here, just a couple of things that we see commonly that don't need a biopsy or further workup. And these are things that can be found in the skin, like a sebaceous or epidermal cyst. Sometimes those are lumps that patients come in with. And when we look with ultrasound, we can be confident that this is a sebaceous or epidermal inclusion cyst that doesn't require surgery or anything unless you yourself want it taken out because it just bothers you. Maybe feeling it, you don't like it in your breast, but it's not cancer. Cysts are very common. Those are fluid-filled tiny balloons that can exist in the breast. That's a very common finding that patients come in with. And typically we can give immediate reassurance at the time of ultrasound. If it is big enough and painful or uncomfortable for you, we can offer a cyst aspiration where we numb up the skin and the breast and we take some of that fluid off. But ultimately, again, if you feel something that's new in one part of one breast, it's just best to come in and get it evaluated. Because in this situation, this patient, we can give reassurance that it's a benign cyst. But in this patient with a palpable lump, this is a suspicious finding until proven otherwise. This looks like a breast cancer. So finally, annual screening, age 40. Please remember, listen to your body. I'm a big believer that women know their bodies. If you notice something that's different, feels different, it persists, please come in and get it evaluated. And then please don't think or assume, oh, no one in my family's had breast cancer, I'm fine. Most patients who are diagnosed with breast cancer do not have a family history of breast cancer. Just wanted to say a plug and a gratitude for Goldie versus Cancer, Amna and her team, Masonic Cancer Center. Every year, we've been hosting this event. And so Goldie versus Cancer at the Minnesota State Fair. This was this past August. These are the breast champions. They go out to local communities in Minnesota to discuss breast cancer awareness and health. And so I was grateful to be asked to participate in that. It was a very great event, raising awareness for various cancers. So I commend Amna and her team. And then this is myself and my colleague, Dr. Jessica Keenheider, who is also a breast center or breast radiologist that I work with. So thank you so much for your attention and the opportunity to speak. I know that's a lot of ground to cover, but I really appreciate your patience and following along.
Dr. Hoven, thank you so much. Thanks for the plug, but then most importantly, thank you so much for providing such an in-depth presentation on breast cancer screenings and what to expect and the risk factors. So next we will be hearing from Lei Simmons. So Lei will share her breast cancer journey with you all today. Lei Simmons is the Executive Office and Administrative Specialist providing support for our team, so the Office of Community Outreach and Engagement at the Masonic Cancer Center. I don't know what I would do without her. She has supported senior management in both the corporate sector and at various departments within the University of Minnesota for over 25 years. And we're so grateful to have her in the Office of Community Outreach and Engagement because she helps us out a lot with various different things. Her passions include encouraging everyone to be proactive with preventative measures to ensure excellent health. As a cancer survivor herself and as a patient currently battling breast cancer, she is also an advocate for empowering and uplifting cancer patients and survivors. So I am honored to introduce to you all Lei Simmons. Please take it away.
Well, hello. First of all, I want to tell you I am 66 years blessed. I'm the mother of 5 children, 4 of whom are living. I have 10 grandchildren and 3 great-grandchildren. Now, I'm the kind of person that likes to tell you a little bit about myself, so here's a little background. In December of 2002, I was diagnosed with cervical abdominal cancer, had surgery in January of 2003, had to wait another 6 weeks and had 25 external radiation treatments and then 3 high-dose implants. At 46 years old, I was sure I had lost the fight several times, but victorious in the end. Fast forward to 2020, and COVID showed up, and I checked out. I didn't want to go out and felt I was taking a big risk every time I set my foot out of my door. I think I went a little COVID crazy. I still contracted it, but sadly, I didn't follow up with my medical appointments, and eventually my health really suffered for it. I joined the Masonic Cancer Center Community Outreach and Engagement Team on January 18th of this year and decided I would be a good team player and attend the fireside chat scheduled for January 27th with Dr. Rahil Gabri. The topic was cervical cancer and the role of regular pap smears and the HPV vaccine in cervical cancer prevention. I was really moved by her presentation and decided it was time to get busy and start being proactive with my health. I honestly thought I was about to embark upon some serious damage control as a result of my neglectful behavior. I made the appointment with my primary physician, who gave me a breast exam and she found nothing, but still ordered a mammogram to be on the safe side. I kept getting exposed to COVID, but finally made my way to have the procedure. Well, then comes the call/letter. Your recent breast imaging examination showed a finding that requires additional imaging studies. Most findings are benign, not cancer. However, additional imaging is required to complete your evaluation. No biggie. In my head, it was going to be like all the other biopsies on my breast tissue. I had several and several tissues removed. Nothing ever came of it. I've had several over the years, as I say. But that wasn't the case this time. The morning of my appointment, when I was supposed to go back, I didn't want to go back. And I sat on my couch and refused to move, and my significant other refused to leave my apartment until I got in the car, and he went with me to make sure I went. I wasn't sure if a 65-year-old me would be able to fight like a 46-year-old me had, and the memories of pain were a bit much. But when I got there, They were really kind to me, and they said, this is a small treatable breast cancer, invasive ductal sarcoma, small. It starts in the duct, and once it breaks through and becomes evasive, then it can become a problem. So, they let me know that there was estrogen and progesterone positive fed by estrogen cancer in my body. And I didn't even know my body still produced estrogen because I had had my tubes taken out years ago. Right now, it was stage 1, based on staging 1 through 4. The oncologist talked. I think I listened, but I was still remembering my last bout with cancer, and everything was kind of a blur. Fortunately for me, the nurse navigator took notes and went over everything after the doctor left, and she let me take those notes home. The next steps would be a lumpectomy, radiation, or mastectomy. Remove the whole breast, most likely not need radiation, no difference in the survival with either surgery. And I made the decision to keep it based upon what their recommendation was. So the plan was radiation, and I dreaded that before they had made a body mold when I had had cancer, and I got zapped in so many places. It was so painful. I didn't even want to think about it. Then they, for chemo as a possibility, they'll check the molecular test. It's an oncotype test, I think, test the genetics of the tumor and gives a recurrence score. If it's a low score, I didn't need chemo. If it's a high score, we would have to discuss it. Fortunately for me, that wasn't what I needed. I didn't have to go through chemo at all. But I would have to go through endocrine therapy, which is a pill taken every day to block the estrogen that helps prevent spread of disease throughout the body. I hope there's not fire in my building, but the fire alarm keeps going off. So at any rate, I'll have to take this pill that helps prevent spread of disease throughout the body for about 5 years, 5 to 10. And the side effects are just hot flashes and joint aches, and I have those already, so no big deal. So I had a lumpectomy on the day of surgery, and they placed a magnetic seed for the surgeon, so the surgeon could easily find the tumor. And then they sent the tissue for evaluation to check for clear margins to see if all the tissue is healthy around the tumor. It was outpatient, and I had 2 small incisions, one on the breast and one under my arm. I waited 3 days, then off to radiation oncology and medical oncology for an appointment. Then radiation started after about 4 weeks after the surgery. So they warned me that I could get a sunburn on my chest and there'd be fatigue from the radiation. This radiation was much more different than what I went through before. Most women have minimal pain with this procedure, and pain medicines are given after the surgery. I did have genetic testing done because my older sister also had breast cancer. The good news was I didn't have a single marker, which was, I was happy. I think I celebrated with a donut. The surgery went well, except that they accidentally glued my nipple to my breast. So that was a little extra pain to endure until I went for my follow-up appointment. But when I showed it to the surgery PA, she immediately removed it. It took about 3 months before the pain subsided. And I was so glad that the surgery was a success that I thought that was a very small price to pay. Radiation proved to be a challenge. Although they were able to concentrate on specific areas, it's much better than it was 20 years ago. I still managed to get an infection and was given meds. The fatigue set in during week 1, but the last 2 weeks were the worst. My breast and the skin under my arm where 8 lymph nodes had been removed so they could make sure it hadn't, spread there. The skin kept coming off. I was given lots of lotions and gauze pads early on to help with that side effect, and believe me, it proved significant. My radiation oncologist shared that her patients that were women of color usually had a more difficult time. And I appreciated her candor. She also took very good care of me. Later, I experienced more pain and attributed it. I just thought it was the radiation pain because my experience 20 years ago was horrific. I would later discover that the pain was actually from an infection and was given medication. And now today I think it's back, so I'm gonna have to go back. But the one thing I want people to know is that if you experience anything, warmth in the breast, pain in the breast, don't wait around. Your body is special and you're special and you deserve to be here. So I also went to physical therapy for a month and was given exercises to help stretch the arm so my range of motion wouldn't be affected, and also to prevent swelling. My arms were measured to make sure I didn't experience a lot of edema, and it wasn't even that bad at all. I've experienced swelling in my breast and leg, but we're monitoring it closely, and they do ultrasounds on my leg to make sure I don't have any blood clots. I don't think I was wait a minute. I don't think I was or am a very good patient. Fatigue lasts for several months, but resting was not and is not one of my better suits. And I didn't like taking oxycodone for the pain, but I finally gave in. I remained at work, a situation that worked out for me because I have a very understanding manager and team. They were so supportive and kind. I was able to work at a pace that didn't stress me or my body parts out. I did learn that typing affected the soreness in my arm and breast fairly quickly. I actually, if you've ever seen those traveling pillows you put around your neck, I would put that underneath my breast to support it and lean it against the desk so that, I could have a good day too. The COE team, community outreach and engagement team, uplifted my spirits on so many days when I felt excruciating pain and was overwhelmed. That helped me to stay in the fight and believe I could make it through every day, and eventually joy would return. I didn't want to I didn't want to stare at the walls alone. 20 years ago, when I had gone through cancer, I had a house full of people. My son and his significant other, my grandbabies, and my daughter lived downstairs in the same building. But that dynamic changed, and I depended on a few friends and my significant other this time around. The more encouraging people, the better. Getting emotional. You definitely need to rest, eat properly, exercise, and keep your spirits lifted. Debbie Downers are not allowed in the inner circle. Yesterday, I went to the OBGYN to make sure my vaginal wall showed no signs of cancer. My oncologist is checking every area there is known to man. She didn't find any lesions or anything suspicious, and the wait is on for those results. I'm here today on a road to recovery because I attended a fireside chat. I hope this will encourage you to share what you've learned today with others. Thank you.
Just a moment here to take it all in, and Leigh's story, but Leigh, you are truly inspirational, and just thank you so much for being with us today and sharing your story with all of us.
I'm trying not to cry.
You did great, so thank you so much. So now we're just going to transition to the discussion portion of our program today. So I'm actually going to go ahead and get our fire going because it's not a fireside chat without a fire. So give me just one moment while I get that started.
Yeah, maybe while you're doing that, Emma, may I say something?
Of course.
First off, thank you for sharing such a vulnerable story. I think that stories are so powerful, and I just thank you for taking the time to do that. I think you said something really important, and that is something that comes up frequently in clinic where I will see a patient and she may be apologetic for not coming in every year for screening. Oh, I know it's been a while. I'm so sorry. I'm so sorry. And the important piece I always say every time is, but you're here now. Like, thank you for coming in. And with COVID, a lot of patients, we were instructed to kind of slow everything down, stop everything. And so as a result, some patients have delayed their screening since. And I fear that sometimes it's of sort of, fear or shame that it's been so long, and it's that initial step of just getting back in the door can be really difficult. And so I just wanted to encourage that piece, like, please come in. We are just excited that you're coming back. I say that every time. Don't be upset that you didn't come last year or the year before. You're here now. Thank you.
Thank you, Dr. Hoven. So we've had quite a few questions submitted. I know Dr. Hoven spent some time answering some of the questions that were coming through the registration. So go ahead and read those if you wanted some of those answers addressed as well. So a question just came through now, Dr. Hoven. If you could kind of reiterate kind of how can breast cancer be prevented? I know you talked about the risk factors, but what more can we do? And you are muted, Dr. Hoven.
Sorry. This is
How did that happen?
I'll just leave it on. I can't stress enough the two most important things. One, that if you are of age, that you're coming in for screening mammograms. And then number two, getting to know your breasts, on your own, getting to know if there are new changes, paying attention. If you develop something different or new, please get that evaluated. Sometimes patients want to go and they want to discuss that with their primary care physician. That's fine, but a new lump, a new change, again, if it's not going away, it's really important to, rather than assuming that it's just benign, oh, it's nothing, it's probably a cyst, make sure that it's confirm that, come into the breast center, get that evaluated. And then I did touch base on some of those actionable items, physical activity, regular physical activity, moving your body, doesn't matter what kind, getting your heart rate up, staying active. We know that the higher body weight you are, that there's increased risk of breast cancer. And so trying your best to maintain a healthy body weight is important. And then some of those other things, choices of, limiting alcohol use, avoiding tobacco, those sorts of things are also important.
Okay, thank you. And so follow-up question, can you discuss more about the home and the self breast exams, and how do you do them properly? Are there guides to do them properly, and how frequently, and etc.?
I try to encourage patients to have a system in place, either a reminder on their phone or the first of the month, every month, to set up a reminder so it's somewhat consistent. And there's really no official way of doing it. Some patients like to go from the nipple and kind of start from the center and kind of work around in circles as you go further and further away from the nipple towards the outer breasts. Some patients like to do their exams lying flat. I think that's a reasonable way to do it. So maybe you're in bed, that's going to be the time you're doing it. And so you're just kind of feeling around. You want to start on one side and kind of mimic that same pattern on the other side. It's important to kind of feel the entirety of the breast tissue. So from the nipple, from the areola around the nipple, all the way up into the armpit area. So all of that could be, could demonstrate signs that would need further workup if there is something that feels different. Some patients like to do their exams in the shower. It's sort of like, I'm in there anyway, I'm just gonna quick do a bilateral check. Sometimes patients like to do sort of like the zigzag, moving back and forth. Essentially, you're just trying to create a pattern of covering all of the breast tissue on one side and then repeating that on the other side. If you miss a month, don't give up and say, oh, I knew I would never do it. But you just want to try to establish some sort of method or pattern to do regularly or fairly regular evaluations of your breasts. And then again, if you notice a spot, you might say, okay, well, was that there before? I'm going to give it a week and see if I can find it again. And if you can't find it, that tends to be reassuring. Mm-hmm. If you feel something new and you're like, that definitely wasn't there, then it probably is a good idea to get that evaluated. Sometimes I ask patients and they say, well, how will I know that I feel a lump? And we have, I love this every year at the breast, Goldie versus Cancer at the State Fair, we have some breast models and there are lumps in them. And patients, or I should say fair goers, if they're around and they're feeling that breast lump or breast mass for breast phantom for a lump, they might keep going. They're like, there's nothing in here. And then all of a sudden their eyes widen and they feel it. And so it's not the same as real breast tissue, but it is a similar concept that just trust that you will notice if there's something there. I see it time and time again that women notice that there's a lump or there's something different. They might not know what it is, but they can point to it. And that's the important piece to keep in mind. I hope I touched base on all of that. Mm-hmm. So I say, monthly, but sometimes it's hard to be that diligent. Just establish some sort of pattern. It might be, like I said, the first of the month. It might be, once every 3 months, but you're still trying to do your best to keep an eye on things.
Thank you. Okay, so Lay had a few questions come through the registration, so I'm gonna target some of those towards you. Let's see which one here. So how do you talk to a loved one about breast cancer, or a breast cancer diagnosis? So you can speak on your experience, just any tips, that you could provide.
Well, I think you should be as honest as possible and share your diagnosis and all the information that you receive step by step. My family and friends always tell me I tell it like it is, but for me, it's better than sugarcoating reality. Your loved ones are as anxious as you are. It's possible, if possible, include them in your doctor visits. But most importantly, if you think they can handle it, let them share in your emotional experience as well. I think it's all part of the healing process. I do wish I had handled telling my grandchildren better. They have books for children and teens like Chemo Cat, Butterfly Kisses, and Wishes on Wings. Because someone I love had cancer, it's a kid's activity book. Or Chemo Shark. Now, see, I really should have got that one. But because the younger grandkids just thought, they associate cancer with death. But they have all kinds of the American Cancer Society. There are different organizations that you can call and just ask them, what do you think is the best way to tell people I love that I have cancer? But most importantly, I think it's good that you tell somebody and you don't go through that alone.
Thank you so much, Lay. And what was something that you had mentioned from your story, Lay, is that you actually ended up doing the genetic testing because your sister was diagnosed with breast cancer as well. So are you having these conversations now with your daughters and like your grandkids?
Oh, honey, please. We have had them with all of my mother's side. Now, my mother is Hawaiian and she came from a family of 12 and my grandmother came from a family of 12, but everybody is on go. I've also, Anna, I told people in my building and I shared with Anna that there was a woman who she had seen they give you a little tag when you go in the hospital. And she actually went to have a mammogram. And this woman was in her 50s. I mean, she wasn't no spring chicken, honey. And they found stage 1 and her prognosis is really good because she had a mammogram. So for me in my house, I'm telling everybody I know. In fact, I was on a call with someone to try and arrange a meeting. And she said, well, how old should you be? I said, do it now. Just do it now. And it's for me, I keep thinking about how I couldn't feel any lumps. My primary physician didn't feel any lumps. But what if I had gone another year or two without it and then come back and it had been invasive and gone everywhere and metastasized? So, girl, I tell everybody I know.
Love it. Thank you, Lay. So actually, Dr. Hoven, going off of that, there was a question that was submitted about just the likelihood of breast cancer spreading to other organs. Does it depend on the stage? At what point should you be concerned about that?
Yeah, it's similar to one of the questions that came in on the Q&A. And sometimes when we have a patient and we're recommending a biopsy, we get a lot of questions like, well, how big is it? What stage is that? Can I get chemotherapy? What kind of surgery can I get? And it can be really difficult to answer those questions without a definitive diagnosis of what the cancer is. Breast cancer is not, we talk about breast cancer, but there are a lot of different parts to understanding a person's breast cancer. It's the size, it's the, Lay mentioned the hormone status. So they test, the mass for certain hormones. And so all of those things go into knowing whether or not a cancer could metastasize or has potentially metastasized. If a cancer is going to metastasize, typically the first place it will go is to the armpit area or the lymph nodes in we call the axilla. And so in our breast center, if we see a suspicious mass or a suspicious finding, again, it's not a guarantee that if we're looking at the axilla, it's not an automatic guarantee that you have cancer, but it's just a sign that we may be a little bit more concerned. We want to make sure that your lymph nodes in the axilla area look normal, because that's going to be one of the first places that cancer cells will go. And then again, to stress the importance of getting a mammogram. Again, if you haven't had one in years, don't worry, please come back. If you haven't had one at all and you're like, I'm 55, I've never had one and I've been okay so far, please go in, because Again, if you diagnose a cancer and it's much bigger in size, the likelihood of potential metastasis increases. So, that's
All right, thank you, Dr. Hoven. So I know you've talked about the contraceptives and the likelihood of increasing breast cancer, the question that just came through now. Do you want to just quickly kind of answer that question for us?
Yeah, I wish I had like a specific study that I could reference, but there have been associations between oral contraceptive use and the potential for increased breast cancer risk or relative risk. It doesn't mean that if you are on oral contraceptives, you are at an increased risk of breast cancer. But so for patients who maybe are newly diagnosed and they're on oral contraceptives, they may be advised or counseled to discontinue that. Whenever this question comes up in clinic, I usually kind of defer to whomever is managing your oral contraceptive use. So your gynecologist, for example, your family medicine physician, for example, to have that conversation with he or she and discuss, I have a significant family history of breast cancer. Are there non-hormone related oral contraceptives that I could use as an alternative? So I think that's how I would address that question.
Great. Well, we're running out of time, so I'm just going to ask you to quickly just share one key takeaway that you would like the audience to take from our session today. So Lei, I'll have you go first.
I think the one key takeaway is that your life and your quality of life is your responsibility. And if you have anything you haven't done, anything you want to do, anybody you want to hug, anybody you want to love, participate. Make those calls to make that appointment. And even if you think a mammogram is scary, honey, planning your funeral arrangements is worse. So have a good day and just take this seriously.
Thank you, Lei. Dr. Hoven.
Yeah, I think that was beautifully said. I love doing these opportunities of community outreach to put a face to a radiologist. I like to share that I'm, having a conversation with you. I'm a human. I try to be someone who's approachable. So it helps to lower that fear of the unknown and coming to a medical exam. And so I can't stress enough the importance of annual screening mammography. And again, please don't worry if you haven't had one or if it's been a while. Challenge yourself today to make an appointment or write down a note to call tomorrow and make an appointment. And if I happen to see you in clinic and you were at this event, please let me know. I would love to meet you. And thank you.
Thank you so much, Dr. Hoven. Love it. So we are unfortunately out of time, so we're going to have to leave it here. Dr. Hoven, Lei, thank you both so much for your time and for being here with us today to help us spread awareness about breast cancer this month. So you will all receive an email shortly following today's program with a link to complete a quick survey, estimated 2 minutes to complete. We would really appreciate if you could spend those moments just to provide us with your thoughts and feedback about today's session. We'll use this information to plan future programs and fireside chats. After completing the survey, you can enter to win a swag bag filled with goodies from the Masonic Cancer Center. And the Amazon e-gift cards for all non-University of Minnesota affiliated staff, students, or faculty will be emailed out to attendees in a few days. So please be sure to follow the Masonic Cancer Center on all of our social media platforms so that you can stay up to date on future announcements and events from the Office of Community Outreach and Engagement. Thanks again, everyone, for joining. Hope to see you all soon. Have a wonderful rest of your day. And special thank you to our speakers today, Dr. Hoven and Lei. Bye, everyone. Take care.